Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other interesting sources in the dermatology community. Episode 13 includes segments on the role of sodium in atopic dermatitis, a paradigm shift in TNF inhibitors, Acanthosis nigricans without hyperglycemia, and a cheat sheet for JAK inhibitors in Alopecia areata. Let's get started. Our first segment is on the role of salt in skin conditions, especially eczema. Dermatology clinicians are frequently asked, what's causing this rash? Is it something I ate? And we usually answer, probably not. But we might start saying, maybe, how much salt is in your diet? Less than 6% of people have food allergies, and only a portion of those cause rashes, as food allergies often cause GI symptoms, such as vomiting and diarrhea. And with atopic, contact, infectious, medication, autoimmune, and other causes, it's safe to say that only a small fraction of cutaneous eruptions are triggered by food. That said, diet certainly plays a role in inflammation and overall skin health, but it's not just processed foods versus antioxidant-rich veggies we're talking about. Surprisingly, sodium may be an important factor in the pathophysiology of psoriasis and eczema. Sodium accumulates in the skin, and a 2013 study published in Nature magazine found that elevated concentrations markedly increase the production of Th17 cells, which in turn produce pro-inflammatory cytokines such as TNF-alpha and IL-17, which drive psoriasis. In fact, the observation that immune pathways are activated by high sodium led the authors to label dietary salt as a risk factor for the development of autoimmune disease. A 2022 study published in the Journal of Investigative Dermatology found that patients with higher PASI scores had significantly higher dermal sodium compared to lower PASI individuals and healthy controls. In other words, skin sodium levels were proportional to psoriasis severity. A response to that article acknowledged the role of extracellular sodium concentrations in modulating nerve excitability and signal amplitude, which have been linked to psoriatic inflammation and itch, but it also pointed out that dietary salt was not measured in that study, and observational studies cannot determine causality. So what's the relationship between sodium and eczema? A 2019 study published in Science Translational Medicine found that atopic skin contains more sodium than non-lesional and healthy skin, and sodium induces Th2 cell differentiation and production of IL-4 and 13. A 2024 study published in JAMA Dermatology found that a 1 gram higher 24-hour urine sodium excretion was associated with 11% higher odds of an atopic dermatitis diagnosis, 16% higher odds of active atopic dermatitis, and 11% higher odds of increased atopic dermatitis severity. Whether a low-salt diet would reduce psoriasis or atopic dermatitis incidence, severity, or flares still needs to be tested. As a therapeutic intervention, it would certainly be a low-cost and low-risk option, but adherence may also be low as it is difficult to maintain reduced sodium consumption. Still, it wouldn't hurt to give your scaly saltines a heads up in case they want to try. Next, is it time for a TNF paradigm shift? Recent dogma-defying data may change your practice regarding patient selection and adjunctive therapy. First is the recent finding that TNF inhibitors may not increase heart failure risk or severity after all. We all learned that TNF inhibitors are contraindicated in moderate to severe heart failure and may even increase the risk of new onset heart failure. But a large-scale meta-analysis published in June 2025 in the Journal of the European Academy of Dermatology and Venereology found that patients treated with TNF inhibitors do not have an increased risk for developing heart failure and no statistically significant increased risk of worsening heart failure. So why the discrepancy? As part of the body's normal defense mechanism, TNF-alpha can be a cardioprotective adaptive response to stress, promoting cardiac cell survival via the TNFR2 receptor. So TNF-alpha is elevated in heart failure. But like all inflammatory processes, too much of a good thing can be a bad thing. and prolonged exposure to elevated TNF can lead to contractility impairment and cardiac remodeling via several pathways, including disrupted calcium channels. So, TNF blockade was initially studied as a heart failure treatment, with no benefit in one trial and worsened outcomes at higher doses in another. Subsequent data and case reports led to cautions and label warnings, but then observational studies and meta-analyses in rheumatoid arthritis showed mixed results in cardiovascular disease. The recent meta-analysis was an attempt to clarify the confusion, and based on their findings, the authors call for updated guidelines regarding de novo heart failure and further validating data regarding the risk of heart failure exacerbation. The other counterculture publication in the recent dermatology literature found that methotrexate may not enhance TNF persistence or efficacy. The study, published in June 2025 in JAMA Dermatology, compared adalimumab 40 mg every other week to adalimumab 40 mg every other week plus weekly methotrexate. The results: drug survival at 1 year, no difference. PASI 75 at 1 and 3 years, no difference. Serious adverse events at 1 and 3 years, no difference. Does this mean that earlier studies showing methotrexate reduced neutralizing antibodies were wrong? No, in fact, this study actually confirmed that methotrexate reduces anti-drug antibody levels. It just didn't seem to make a difference. Anti-drug antibody levels at 1 year were lower in the methotrexate arm, but there was no difference in adalimumab concentrations at 1 year. Next, what do you do when a patient with Acanthosis nigricans has a normal HbA1c? You check their HOMA-IR score. Acanthosis nigricans without elevated blood glucose is relatively common in obese adolescents, lean individuals with familial insulin resistance, polycystic ovarian syndrome, and African American and Hispanic patients. In fact, a study of indigenous Australians published in 2019 in the Journal of the Endocrine Society found that 85% of those with Acanthosis nigricans in adolescence had a normal A1C for up to 7 years after the acanthosis was first identified. And a study of Jamaican adolescents published in BMJ Open in 2013 found that while Acanthosis nigricans correlated with various markers of metabolic syndrome, there was no statistically significant link between acanthosis and elevated A1C. Why? Because Acanthosis nigricans is an early marker of hyperinsulinemia, not hyperglycemia. A1Cs measure hemoglobin glycation, which occurs after insulin resistance progresses to the point that insulin can no longer keep serum glucose in check. So a patient's A1C can be normal despite significant insulin resistance as measured by an oral glucose tolerance test, or the homeostatic model assessment of insulin resistance, or HOMA-IR. Instead of being a marker for blood glucose levels, the HOMA-IR measures how hard insulin is working to keep glucose controlled, so it will detect insulin resistance before blood sugar and the A1C go up. So how do you get a HOMA-IR score? You order a fasting blood glucose and a fasting insulin level, then plug the results into an online calculator such as MD-Calc. Cutoff values can vary by population, but generally below 1.0 is considered optimal. Over 2.0 suggests early insulin resistance, and above 3.0 represents significant insulin resistance. But don't worry, the calculator will guide your interpretation of the results. Are there other HOMA-IR versus A1C differences? Yes. HOMA-IR does require fasting. It provides a snapshot of the patient's insulin resistance at the time of blood draw, kind of like a cholesterol level, rather than reflecting a 2 to 3 month average like an A1C. And it is not affected by anemia, thalassemias, sickle cell disease, or liver or renal dysfunction, though insulin resistance can be transiently affected by corticosteroids, stress, and alcohol consumption. So go ahead and get an A1C, but be sure to get fasting glucose and insulin levels too, so you have the complete picture. And finally, with Leqselvi now on the market alongside Alopecia areata OG's Olumiant and Litfulo, how do you choose? Our most recent network meta-analysis, published in April 2025 in the Journal of Cosmetic Dermatology, found that, quote, there was no significant difference in efficacy between duruxolitinib 8 mg twice daily, ritlecitinib 50 mg once daily, and baricitinib 4 mg per day, close quote. The 2 mg dose of baricitinib didn't do as well, but otherwise they're all good options. So how do the recently released Phase 3 data for Rinvoq and Alopecia areata stack up? We all know you're not supposed to compare data from separate trials, but when you've got new data that's not included in a meta-analysis or a head-to-head study, what are you going to do? So here's a snapshot of each JAK inhibitor's Phase 3 trial data. Note the results are the rounded pooled proportion of patients achieving 80% scalp hair coverage. We'll start with baricitinib, brand name Olumiant, by Eli Lilly and Company. It's a JAK1/2 inhibitor for patients 18 years old and above, and their study participants had a mean SALT score of 85 and a primary endpoint measured at 36 weeks, at which time 34% of their patients achieved 80% scalp coverage on 4 mg QD compared to 4% on placebo. Next, ritlecitinib, brand name Litfulo by Pfizer. It's a JAK3 TYK inhibitor for patients 12 years old and above. Their study participants had a mean SALT score of 88 and a primary endpoint measured at 24 weeks, at which time 23% of their patients achieved 80% scalp coverage on 50 mg QD compared to 2% on placebo. Then duruxolitinib, brand name Leqselvi by Sun Pharma. It's a JAK1/2 inhibitor for patients 18 years old and above. Their study participants had a mean SALT score of 87 and a primary endpoint measured at 24 weeks, at which time 30% of their patients achieved 80% scalp coverage on 8 mg BID compared to 1% on placebo. And in the pipeline, upadacitinib, brand name Rinvoq by AbbVie. It's a JAK1 inhibitor for patients 12 years old and above. Their study participants had a mean SALT score of 84 and a primary endpoint measured at 24 weeks, at which time 45% of their patients achieved 80% scalp coverage on 15 mg QD, and 54% achieved it on 30 mg QD, compared to 3% on placebo. Notable differences between them were baricitinib's primary endpoint was 36 weeks versus 24 weeks in the other trials. Duruxolitinib's dosing is twice a day versus daily for the other medications, and duruxolitinib requires CYP2C9 genotyping prior to initiation. By the way, if you use a specific test code, that will get charged back to Sun. Talk to your rep about that. And ritlecitinib and upadacitinib include pediatric patients. If you're looking forward to getting your hands on upadacitinib for your alopecia areata patients, FDA approval is expected towards the end of 2026 or early 2027. And that wraps up episode 13. Derm Drop is written and hosted by me, David Sider, with production and distribution by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Seiter, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. If you learned something useful, hit the thumbs up button and tell a friend. And thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.